Okay.
Okay.
Sorry, we've got a bit of an echo. I'm not sure why. Okay, I'll try again. Hope the echo's gone. Seems to be, yeah. Okay, welcome everyone to this meeting. Can we move on to the next slide? Yeah, okay. Just a reminder of the kind of the housekeeping, and let's hope we can all use it on it. The technology works, because as we know, sometimes it can be a bit challenging. In terms of apologies, we have had a higher number than usual today. I suspect it's got to do with, annual leave and holidays, etc. But we've got about 16. I won't read them out, but we'll add them to the minutes. Lisa, you've had a few more as well, haven't you? Lisa,
Thank you. So I've had apologies from Jerry Wigfield from the South Bucks Hospice, which I caught up with him yesterday, and also Dawn Allen from the Henry Allen Trust and Milton Keynes Cancer Patient Partnership.
Okay, thanks everyone then. Okay, let's move on. Can we welcome Kathy? Are you here? Oh, you are. Yes. I can't actually. Well, welcome, Kathy, and you, managing director.
I'm here for the first sort of couple of minutes, so apologies, but really nice to see lots of lovely, smiley, happy faces that I can see. I'm Kathy Wybrow, the incoming managing director for the Thames Valley Cancer Alliance. So really pleased to be here and to hear all the great things you're doing. And me and my colleagues, Lyndall, Lisa and others will do everything we can to support yourselves to make sure the patient's voice is heard across the cancer pathways particularly. So thank you very much for inviting me along today, William, and apologies I have to sort of leave a little bit earlier, but we'll come and speak to you all at various points, I'm sure, as I start officially. Thank you.
Okay, great. In terms of the minutes, does anyone have any issues about the minutes? Okay, let's move on to the action log. I think has been circulated. They're all either complete or in progress, apart from one, which is in red, which is to do with the dashboard feed number 18. Lisa, anything you want to add to that?
So I'll pick that up if you like.
Oh yes, please, Lyndall. Yeah, please.
Because that was from the last meeting. Victoria is going to share the dashboard sort of frontline sort of headings on cancer performance. So she's been on leave. I'll follow that up. And actually what we did say at the last meeting is sort of fairly regularly, we'll invite her along to share that sort of cancer performance dashboard update.
I mean, can I just add to that, Lyndall?
Yeah,
sorry. Just only because I've seen a lot of these dashboards and I've been working in cancer for a long time, and a lot of them don't make sense. So I really don't want her to send out the dashboard that we would have internally for our own consumption. So we'll make sure that it's user friendly. We'll get the points across. So Lyndall, I don't want her just to send out the dashboards, which will mean very little to people because they'll have to have lots of explanation behind. So we'll do some. We'll do some further work on that, and it maybe we ask one or two members of your group actually to support us to do that piece of work to make it much more user friendly, because at the moment it really isn't sort of ready for sort of, not being disrespectful, for everyday consumption as it were. So we need to make sure you have a view on that.
So Kathy, what happened was at the last meeting, Victoria shared the dashboard and some of the cancer performance. And so she did explain where we're at with cancer performance across the Alliance, and did present it in a user-friendly way, I think, or there were questions around it. And it was just more sort of keeping that regular update for everyone.
Happy with that, just to make sure that it's forward consumption, it goes on further, what it really means. So we just need to look at that, that's all. But yes, I'm sure she did a very good explanation on what it means. Thank you. William, you're on mute. I don't know if you're trying to move things forward.
I don't know how that happened. Anyway, item 2 then, my update. Now this is going to be brief because the main item sort of follows up with Lindell on about the workforce. But here you go, a picture of Kathy, as well as what you can see on the screen. But then in addition to Kathy, the executive board also has a new chair. This is Megan Pandit. She's currently interim chief executive at Oxford. I think that's probably at least for the next 6 months or so. So it's good that she's come in and she's really taking a grip, and she certainly has a different style of chairing than her predecessor. Okay, if we can move on to the next slide then. A lot of what we talked about, we've just been touching on the issue about performance. There's some kind of very stark figures here, which I think it's very important to share. So, you know, we only sort of reach compliance, overall compliance, that you see what the figures are there for October. They're not very pretty, but there was kind of clear action agreed. Can we have a look at the next one, please? This goes into a bit more detail in terms of looking at each of the trusts that referred for the July meeting, provided these figures. And again, I think this really focuses down on the kind of the issues and the challenges that we're facing post-pandemic. Now, Kathy, anything you want to just add why we have you before you have to disappear on this kind of performance issue?
Yeah, I mean, just to say that we're clearly really disappointed that our performance isn't as good as we'd obviously want to provide to our local sort of communities. And in fact, I've got a meeting tomorrow with the ICB, but also with the local trust to look at, again, looking at our action plan to see what we can do to support them even further. So it is a massive focus for us. We really want to get it right. We really want to bring these numbers down and hit our trajectories, to make sure patients are safe. So, we're really aware of it, and we will be doing as much as we can. I mean, a lot of the issues are around sort of staffing. So what we're looking at is where we can bring sort of digitalisation into some of our solutions, and how we can innovate pathways going forward with whatever it might be, whether it's artificial intelligence, etc., to try and support some of this workload. But we are, really keen to reduce the backlog and to make sure our patients are seen within these times, if not even sooner. And we will be working with each of the trusts to look at a tumour site level. So we'll go through our clinical CAG groups, but we'll start looking at what action plans we have at a tumour site level to address this. Some of it can be done at sort of a generic level. Some of it we know is around validation, where we've got patients on lists that shouldn't be on lists, etc. So some of that we can take off quite quickly, we hope. But there are obviously some patients in there sitting in the system which we need to get treated fairly quickly and fairly urgently. So we're picking that up with our consultant colleagues and nursing colleagues across our system.
Okay. Does anyone have any? Patrick, you want to add something on this?
Yeah, just a quick comment, really. I mean, it's great to welcome Kathy and congratulations on your appointment. But it's great to hear the commitment. But to be honest, we haven't met targets generally for years, and the commitment has always been there. And I'm full of admiration for those people working at the front in very difficult circumstances. But in all honesty, is there any reason for us to be optimistic about things improving for cancer patients and their families?
I suppose, I mean, you're quite right, Patrick. And of course, I've been, living and breathing sort of cancer for many years. In terms of my work, but also in terms of sort of family, personal life. So I've gone through the tragedies of cancer, so I know it is really painful for people to do this. We have always had a backlog, there's no doubt about it. It's got compounded and made much worse with COVID and all the issues that we've had surrounding that, which you're all aware, because that's over the sort of, the news, etc. I suppose what we can say is it really is top of the office. So we have got the sort of ministerial ear, the national cancer team are really linking in with the ministers around this. This is a top priority. They have given us funding, but But we know that sometimes, even with funding, it's not always the answer to things, because it is about staff and it is about the skill set, and we know that takes a long time to work through. So we are looking more iteratively at how we might do things differently, and we're working through the clinical teams to look at what's safe, what we can do, and looking across the whole system. So we're not focused always on secondary care, that we're looking at where we can bring in primary care, community care and other clinicians to sort of support us. So, you know, we're very happy, and we will share with you. We've just literally put out to all of our system ideas for innovation, ideas for sort of how we might, you know, pilot different ways of working this year going into next year. And we're happy to bring them back and share them with this team, and to get whatever ideas that we can from this group to how we might be able to support it. We're very clear that we need to have the human touch, but where there are things that the clinical staff are doing that don't add value, where it might be admin or other things, we will look at either admin or digital solutions to support that, to free them up for the time that they, you know, they have to be sort of patient and you know, focused.
Okay, thanks, Kathy. Alex, you want to comment or a question? You're on mute. You're still on mute, Alex. There you go. That's
I've managed to sort it out. Thanks. Those are interesting numbers, but they're absolute numbers, and I have no feel for the context in which those numbers exist.
Right.
Can we get a bit more background? Like patients receiving first definitive treatment for all cancers within 31 days. That's a useful number, 160 and 170. But how many didn't receive their first definitive treatment?
Yeah, I think that's more important. I think that's an important question. We may not be able to give the detailed answer, but Kathy, do you want to come back on that?
Well, so that's the sort of thing that we need to, you know, it's a really good question. Thank you for raising that, because what we need to do is put these into percentages and put them into whatever. So we can do that through the work that we'll do with Victoria to make it a bit more user-friendly, as it were, so we don't just have fixed figures. But yeah, we can take that away. We might not be able to bring it all to you. It might be a work in progress over the next few months, but we can make it more real and you know, sort of viewable, as it were.
Thank you, Kathy.
Okay, Rob, you want to come in? Are you there, Rob? Hello, Rob, are you there? Still showing a hand, but you're on mute. Okay, well, while we're waiting for, oh, there you are. You're off. Go ahead, then, Rob.
Okay, thank you very much. I'll be brief. I mean, just listen to the conversation we've just been having. And I agree with the earlier speakers that I've absolutely no doubt whatsoever, over a long period of time, a huge effort is being made, and I acknowledge fully that. However, sitting here thinking about this, what can you really do to really make a significant difference to this? What can we really do if we had a wand? What would we do? I hear that we're short of staff, but there must be other reasons. Is there something we can actually do as a group to think about what you can actually do to move these figures in the way that we clearly would all like to see? Thanks.
Okay, thanks, Rob. Kathy?
So, Rob, that's not a one-word answer. I think if we had a magic wand and do it, life would be so much simpler. I think it's so multifaceted. Cancer is so complex, and there are so many different things we would do for each of the different tumour sites. But there are things we can do from a patient's perspective in terms of really raising the awareness of things like fit tests, and for men to do PSAs, etc., to look at how we might support some of those cancer pathways. So if we can get earlier diagnosis or earlier symptoms picked up through the primary care, through GPs, that will, in the long term, sorry, I've got something on my door, that will in the long term really help us to prevent people getting to that much more aggressive stage of cancer. But Rob, we'll go back to you. We've got a whole big plan, which I'm sure Lyndall and others have probably shared with you, to look at some of this. So there's loads, and there's loads of stuff we can do around sort of AI, you know, around different uses of equipment that we can use to sort of try and support some of this stuff, both in the community and within secondary care. Sorry, I've got dogs barking in the background, so apologies on this. But I will come and join you again in the future, and I'll pick up anything from Lyndall and Lisa after this meeting. But we can come back and share, especially when we've got the programme and plan in place, the sort of ideas we've got, and then let's listen to some other ideas that you might be able to add to that. Would be brilliant. Thank you.
Thanks. Okay.
Thanks for your time today, everyone.
Okay, let's move on to the next item, which is directly connected, because one of the in addition to looking at performance, the executive considered quite a detailed presentation from Lyndall on the workforce issues, and we know how critical they are to the stats that we've just been talking about. So, Lyndall, over to you.
Thanks very much, William. So yes, Lyndall Moore, I'm the lead cancer nurse at the Thames Valley Cancer Alliance. Just to go back to the previous conversation that we're having, and just to support what Kathy was saying, you may recall at the last meeting that we had that we actually shared the national operational guidance. So there were some priorities that TVCA had for that the ops guidance, and that includes sort of work around cancer performance, faster diagnosis pathways. It also, earlier diagnosis initiatives with the targeted lung health check, fit testing, etc. And then also around personalised care and supporting people to live well following their treatment, their diagnosis and treatment for cancer. So there's multiple elements of work streams, and what we will do at each of these meetings, and what we've tried to do, is bring various elements and discuss those, so you have an oversight of what nationally is trying to be achieved, and also regionally, and then within the trust. So I hope that helps sort of finish that previous conversation that was had. But my purpose here today is to talk to you about the oncology workforce, which I shared at the board recently. So, I mean, I think you will all appreciate that, you read the BBC News or whatever news outlet, there's always information about the pressures within workforce, and particularly within the cancer workforce. I just want to sort of support my colleagues out there. As you've all commented, people on the ground are working incredibly hard. I'm incredibly proud of the efforts that are being made in all of the trusts by staff. That following, a couple of years of a pandemic and people being exhausted, they're still continuing on working very hard and trying to ensure that every patient that is one of those numbers that we're commenting on being treated is being treated as an individual, and we're trying to ensure that they're being treated as quickly as appropriately as possible, really. But there are challenges within the workforce, whether people have been off sick with COVID or struggling with the pressures that have been experienced over the last couple of years. And in particular, we know the oncology workforce is under pressure. And there was a big piece of work that's done here. You can see this was done by Dr. Jeanette Dixon, who is from the Royal College of Radiologists, and they did a survey back in 2020, which showed some of those workforce pressures that are being seen and the impact that's being had. So this sort of provides us evidence that is actually being shared across the teams nationally. And we had in May, a specific meeting that was held on the 6th of May, which was a Southeast regional meeting, which was actually looking at oncology workforce and what the teams on the ground are experiencing and what we can do to try and support that oncology workforce going forward. So it is being heard at the higher levels within NHS England, and we all very much want to work together to try to support teams to deliver on their services. Some of the things that she commented on and that actually came out from the report are things of using, AI that we've discussed, which would actually help with some of the radiotherapy treatments and efficiency in delivering that. Looking at role extension, that's certainly something that we're doing within Thames Valley, and we've actually funded some additional posts which trusts are sort of piloting, and where we learn see improvement in delivering those services. We will look at how we can share that best practice across the Alliance. And I'll come on to that a little bit later in the presentation, but also sort of considering around their training, the number of training places, and to ensure that there's appropriate job planning to support the consultants and the medical teams within that. There was also Professor Geeta Menon, who's the lead dean for the Cancer and Diagnostics department of the Health Education England, and she spoke about medical training. And so we have seen an increase in medical training numbers in the last year to support the shortfall in medical and clinical oncology consultant numbers. And certainly within Thames Valley, that was a conversation that we had at board of ensuring that all of the trusts are there and supporting and giving financial contribution to the training of more oncology doctors coming through. So we can look at all of the different workforce and look at alternate roles to support. But what's really important is that we do actually need the right number of oncologists to help. So they're involved in supervising a lot of the role extension staff and doing their own role. And what is the positive is that we know that people are living longer with a cancer diagnosis. And those with metastatic disease are also living longer with new lines of immunotherapy and treatments, which is fantastic. But we do need to have the right workforce behind them to help support those patients and the staff in delivering that care. So one of the things that we're doing within the Alliance, and thanks for moving that on, Lisa, is that with Bob ICS, so the integrated care system that we sit within, Bucks, Reading and Oxfordshire, as well as we're sorting funding for the Great Western and Swindon, and Frimley have some funding through Frimley ICS. They have engaged Alison Aylesbury, who is working with Health Education England, and she's an economist who, a health economist who is actually helping with scoping the workforce. So basically we're doing a deep dive into each trust workforce and working with them where they understand what is their baseline of staff numbers and how they're delivering their services. Are there different sorts of transformation work that they would like to do? What type of staff would they need to help with delivering those services, and trying to come up with a workforce plan that is sensible for that organisation to help deliver their cancer services. So that process is currently in place and is being worked through. And if we move to the next slide, please, Lisa. Health Education England have a well-known methodology that they use and where they look at using STAR workshops, and that is very much looking at your supply of staff, what you need to do to upskill staff, what types of new roles might be helpful to deliver that service, and then also looking at, are there any different ways of delivering that service to support it, and also the leadership and support that's needed to do that. So all of the trusts are currently in this process of reviewing their workforce. And if we move to the next slide, please. As I said, that's currently underway, and we hope to have a draft report, hopefully in the autumn. I would say it's in October that we will have potentially that first draft that we will work with. And then, as I commented on, we have looked at some alternate workforce solutions to help support our medical colleagues and delivering appropriate cancer care. These can include physician associate roles, which has been undertaken very successfully at Royal Berkshire Hospital, and they're sharing that knowledge and practice with other trusts. We're looking at advanced clinical practice roles, particularly with funded roles in breast cancer, chemotherapy or SACT treatment, also in pharmacy consultant roles, and also a consultant role in therapeutic radiography. There's also different roles within what we call patient navigator roles to try and support the patient through that whole pathway. And then also digital solutions are really important with trying to help services being more efficient. And if we move to the next slide, please, Lisa. We've also done quite a bit to try and support the training and education of our staff, working closely again with HEE to fund university placements and courses to develop the appropriate skills and expertise in cancer care. And also we've sort of found appropriate advanced comms courses for the clinical staff, and also in this next year for non-clinical staff. And one of the good things that sort of come out of this is that we've developed some communities of practice, which is particularly in acute oncology and chemotherapy. So the staff in each of the trusts can actually share some of their good practice, and that we're learning across the system and not working in silos within the Alliance. Medical support worker roles are another area of exploration, and this is a fairly new project that's happening in the Southeast, and it's actually looking at staff that have come from countries where they need to become registered with the GMC, and during that time, and perhaps needing clinical supervision to attain the right proficiency in the role, or to be able to have their role registered with the GMC, they can do these medical support worker roles, and that's been found to be quite efficient, that you can link into an appropriate team. Where we're looking at that within cancer care, but again, they need appropriate supervision with the oncology team or cancer, whatever team that they're working within. Potentially, we could look into international recruitment, but ensuring that that is ethically done. And then to try and support us with all of the workforce demands and pressures, and as I said, to work as a system and to share and support each other. There's going to be a Thames Valley Cancer Alliance workforce steering group, and that first meeting is going to be later this month, and there'll be representation from each of the trusts with that. And we will explore a lot of the topics that I've mentioned now. But one of the other really key things that I think we need to remember is supporting our colleagues with their health and well-being. So it's not about pushing people to do more and more and more. You know, we need to make sure that people are well looked after working within the NHS, and we're looking at scoping some compassion fatigue courses and other things to try and support our colleagues during this time. So that is talking about what I shared at board. Before I move on to the next element, has anyone got any questions for me? That's a very quick overview of what we're trying to do, but hopefully it gives you an understanding that there is work being done across the Alliance. But a lot of these workforce solutions aren't quick fixes, and they're things that we need to do over the coming years to support staff and trust with having the right workforce to go forward.
Okay, thanks, Lyndall. Do you want to talk about the steering group then?
Okay, so then with the steering group, we very much would like, I think Claire was at the last meeting or the meeting before, and she spoke about having a couple of patient representatives on our workforce steering group. We do have a job description that I think Lisa has actually shared, and we'd love to see a couple of, well, you know, people put their names forward. If you could express your interest to Lisa by Friday the 16th of September, that would be fantastic. And then we can have some introductions with Claire, who's the workforce program manager, later in September prior to the first meeting. But basically that is, as I said, bringing people together from across the Alliance with the ICS, so we're all working together, looking at our workforce requirements in a very brief summary. Lauren.
Okay, thanks, Lyndall.
Hi. Oh, hi, Lyndall. Sorry,
hi.
I just wanted to quickly say that the TVCA Cancer Champions with the CNS group, I think, has been really proved to be quite successful in understanding some of the challenges. Sometimes people can't attend due to work commitments, but I think if we push that on the agenda, that's really useful moving forward as well.
Okay, thanks, Linda. Emma?
Hi. Oh, hang on. I'm back in now. Sorry. Problem with the mute button. I had a meeting with Lisa the other day, but just to say, I actually work with the patient participation groups across Oxfordshire within my role at Healthwatch Oxfordshire, and actually I'm more than happy to share the patient involvement role across the PPGs, if that would be helpful. I'll put my email address in the chat box, and more than happy to share that. I send out weekly emails, so if I get it quite quickly, I could send it out this week for you.
Okay, thanks, Emma. Well, I hope some group members will, you know, consider this. Obviously, you know, we all have demands on our time, but please do have a look at the the document that Lisa circulated. And if you're interested, please submit an expression of interest. Okay, thanks everyone. Want to move on to the next slide? Okay, I mean, we've been talking about ICSs, which are kind of a major change in how we're all supposed to work together as sort of, different organizations. And I think this very helpful King's Fund video, I think, begins to put that in some kind of context and tries to explain how are things changing and how might it work. Lisa, do you want to start this running? For the technology grind is slowly on. Yes. Lisa, we don't seem to have any sound.
Are you able to hear that, everyone?
No, there's a problem with the sound,
Okay.
Lisa.
It might be because you're muted, but try.
Oh, okay, sorry. Bear with me. Right, let's
see if we can
again.
start it again. There we go. We have the technology.
Big changes are taking place across the health and care system. What does this mean for the organisations that make up the NHS? How will they collaborate with other parts of the system? And what will these changes mean for you and me? When the NHS was set up, it focused on treating single conditions or illnesses. Since then, our health and care needs have changed. More of us are living longer, and many have multiple conditions that require regular, ongoing care. However, this hasn't been reflected in the NHS's structure, a patchwork of organisations that often work independently from one another. Navigating this can be confusing and can have a negative impact on our experience of care. So, for some years now, health and care staff and leaders have been working to bring organisations closer together to better meet our needs by working in a joined-up way. Primary and secondary care, social care, mental health and community health services have been seeking to partner with each other in different ways. At a very local level, GP surgeries have been coming together to form primary care networks, groups of practices working together across areas called neighbourhoods. By sharing resources and working closely together with other local people and services, they can provide a wider range of services than a single GP surgery. Health and care organisations have also been working together across larger areas called places, often covering the same area as a local authority, where large parts of the NHS budget are spent. Here, local government, charities, residents and NHS partners can work together to understand and meet local health needs. But previous laws have prevented services becoming even more joined up. The 2022 Health and Care Act aims to change this and make it easier for organisations to work together. But what do these changes look like? Organisations are now coming together across even larger areas to form integrated care systems, partnerships of health and care organisations that plan and pay for health and care services. There are around 40 integrated care systems across England, and although they've existed for some time, the Health and Care Act gives them legal status, as well as new powers and responsibilities. Integrated care systems are made up of two parts. integrated care boards, and integrated care partnerships. Integrated care boards decide how the NHS budget for their area is spent and develop a plan to improve people's health, deliver higher quality care, and better value for money. Integrated care partnerships bring the NHS together with other key partners, like local authorities, to develop a strategy to enable the integrated care system to improve health and well-being in its area. NHS trusts are also coming together to form provider collaboratives, new partnerships that can bring together providers such as hospitals, mental health services, and community services. So how are these new structures funded? Integrated care systems get most of their money from NHS England, which is the national body for the NHS in England, and sets the operational priorities for the health system. It's responsible for the health services you and I access day to day, which are inspected and regulated by the Independent Care Quality Commission. The Department of Health and Social Care sets out what the NHS is expected to deliver for the money it gets from the government, which comes from our taxes. It also holds budgets for some of the other areas that have an impact on our well-being, like public health. Throughout these new structures, local authorities play a key role. They receive money locally and from national government, which goes towards funding a range of services that support our well-being and prevent ill health. So, what does this all mean in practice? The Health and Care Act has put in place a legal framework that enables services to work more closely together, so it's easier for you and I to receive the care we need, when and where we need it. For these changes to succeed, staff and local leaders will have to work with one another differently, alongside key partners in local government, the voluntary sector, and communities themselves. Of course, services face other challenges like workforce shortages, growing waiting lists, and the impact of the COVID-19 pandemic. While the new structures won't fix all these issues, by enabling services to work more closely together and join up services for patients, it's hoped that the health and care system will be better able to meet our changing health and care needs in the future. Find out more about how the health and care system is changing at www.kingsfund.org.uk/explain.
Okay. I hope you find that helpful. I mean, I think we've had obviously yet another reorganisation and sort of structures. This one came in from the 1st of July, so I think it still really has to demonstrate its efficacy as we go forward. And we're all sort of keeping our fingers crossed and sort of, you know, trying to ensure that we all collaborate together to try and make it work. Lisa, can we just move on to the next slide, please? Okay, so in terms of us, we're in what's called BOB. So the shorthand there, Buckinghamshire, Oxfordshire and Berkshire West. You can see the stats there, 1.8 million. I'm not quite sure what's happened there. 1.8 million for the population, 3 clinical commissioning groups, all of which are kind of no longer exist as a result of the ICS. They all come together. 5 Health Watch, 14 local authorities, 160 TV practices, etc., etc. So it's we're talking about a large number of organisations trying to look at how we can work best together across a very widespread area. Next slide, please. Yeah. So these aims come from the original legislation. So it's about being very clear about how do we genuinely improve outcomes in the health of the populations. And by outcomes, we're talking about the changes that make a real difference to people's lives. So it's not just about outputs. It's not just about counting the numbers going through, although we need to have more people going through and getting treatment faster. This is about what are the actual differences that are going to make. Tackling inequalities, I think, is very significant and very important, but also very challenging. And inevitably, we're looking at how can we all do this in a way that generates value for money, and how can the NHS support what's going on more broadly in terms of social and economic development, which I think is a particular challenge in the context of the NHS's own internal challenges. Next slide, please. This is just another way of kind of demonstrating what the kind of, the key focuses are. So start well, very much looking at child health and, how do we ensure that we have a healthy population and good maternal care, etc., etc. Live well, very much about sort of ongoing health education and well-being. Third one, age well, for those of us who are getting on a bit. How do we ensure that there's appropriate support for those of us who, as we age? Number 4 is a bit of a challenge. We all know how big a challenge it is in terms of growth at the moment, and we know it'll be interesting to see how that is affected by kind of recent governmental changes. And then last and by no means least, reducing inequalities, which again is something that we would all want to contribute to, but is a significant challenge. Next slide, please. This is just a way of sort of trying to look a bit about sort of what was highlighted in the Kingston video, looking at the different bits of the system and how they're supposed to interrelate. So if we look at the blue jigsaw piece, the ICB is the key kind of strategic thing in the structure. The Bob board is chaired by Javed Khan, who's previously was chief executive of Bernardo's. And I've had a number of conversations with Javed, and he's very keen to try and make all this work, but he recognises the challenge. The purple one at the top, the Integrated Care Partnership. So while the ICB is an internal health service structure, the ICPs are mechanisms that allow partners, including local authorities and the voluntary sector and the NHS, to come together and work, how does that work in practice? So that's got more to do with kind of overseeing the operation and trying to make sure that actually, as partners, we're all working together. Now, I think there's a lot of work to be done in sort of trying to develop that in the first place, and an awful lot depends on the trust that is developed amongst different organisations, and that in itself, I think, is a very difficult challenge. And then over to the right-hand side, place-based partnerships. The legislation, talks about, the system and places and then neighbourhoods. So, the places are those 3 areas of Bob. And obviously within each of those places, there are lots of different neighbourhoods. But that's again working at that kind of local authority type level to making sure that things are working well. And last and by no means least, provider collaboratives, which are kind of providers getting together and look at how they can do things better. And in fact, TVCA is technically designated as a provider collaborative in terms of these kind of ICS roles. Next slide, please. Okay, so building partnerships. You can see what's spelled out there in terms of the duties, etc. And it's all about us working more effectively together. Now, these, and the term that's sort of put together is voluntary community and social enterprise sector, VCSE. And I'll say a bit more about that at the moment. It's a bit of a mouthful, and I must admit I tend to talk about the voluntary sector as a shorthand, so that's what I'll probably carry on using. But this was based very much on guidance developed by a number of organisations, National Voices, the Patients associations, Health Watch, etc., and they developed the guidance that is reflected in this triple aim duty. Okay, so next slide, please. So in Bob, we have a health alliance, which was set up in January 2020, and very much initiated by what you might describe as infrastructure organisations. People might recognise them as sort of, voluntary action or old councils of social services, a more old-fashioned name. But what they're very much focusing on is looking at how can we genuinely enable partnership between the ICS and the voluntary sector, recognising that the voluntary sector is in terms of power, authority, resources, is in a lot weaker position than other partners. And then how can we enhance the role of the voluntary sector in terms of strategy and development, and both in terms of design and delivery. And I mean, one of the things I've talked about before is the importance of design in terms of looking at us working jointly and together to develop services, rather than it sort of coming through as a kind of a top-down approach. And I think there's a genuine commitment within the ICS to do that. But again, we'll have to see how it actually develops in practice. Next slide, please. Okay, this is the final slide in this kind of presentation, and it's really just trying to lay out in a schematic way what the different levels are. Excuse me. So you're talking about what I was saying at a system level, and in terms of the Bob ICS, this is a diagram that tries to demonstrate what the voluntary sector alliance structure is. So it's got a steering group at the system level. It's got people involved at a place level, and working hard to get more people involved at a neighbourhood level. Those little arrows at the bottom says work stream. That's really got to do with kind of we've got specific groups who are involved in work with particular client groups, whether that's to do with learning disability, mental health, a whole kind of range. So it's trying to look at bringing together organisations who are interested in particular groups and trying to find a way of trying to make sure that they can work together and can feed into what's happening in the system. And then the final point at the bottom, ICS representation. What's actually worked out since this slide was developed is that the voluntary sector representation is going to be on the ICP, not on the board. And that's interesting, but again, we'll just see how that develops. Okay, that's the sort of end of the presentation. Does anyone have any comments or thoughts or questions before we move on? No. What I didn't say is for my sins also a chair of the Alliance, and I've been chair since February this year, so I'm still learning. There's still a lot of work to do. But what we are beginning to see is now that the official date for the ICS has passed, we're getting to actually have more people actually engaging. Rob, do you want to come
in? Yeah, can you hear me?
I can, yep.
Yeah. I mean, that's a very detailed, complex presentation. To take that all in one shot is actually, well, for me, even a bit tricky. But I mean, there's a lot of good stuff in there. What my view there was, there was a lot of good stuff there. You're talking about the voluntary sector, quite a lot in there, and they do have quite a role to play here. One of the big issues with the voluntary sectors is both recruitment of, I know you're talking about recruitment in NHS, well, recruitment in voluntary is just as difficult, if not more so, in my experience. And of course, financing them. And I wonder if there's any thought given to how you might think about how we move that ahead. Tricky question, I know.
No, I think they're important questions. I'm not sure I can, give appropriate answers. Excuse me. Certainly, the voluntary sector has for years faced resourcing problems, and we have, the voluntary sector is one of those kind of phrases which I think, covers a whole kind of range from the very small community organisations to advocacy groups to other organisations who are, providing services under contract. So that certainly the whole kind of thing about resources continues to be a problem, and bringing in a new structure doesn't provide any kind of easy answer to that. I recognise what you say, Rob, about the complexity of kind of what's going on. And I've tried to make that as simple as possible in the presentation, but obviously, I haven't totally succeeded. But the slide pack will be available after the meeting, so you'll be able to sort of have a look at it and hopefully, get a bit more out of it when you've been able to see it and look at it at your own pace.
Yeah, that was going to be my next question. Is could we have a copy of the slides?
Yeah.
And I would just add something which is probably the blindingly obvious, but I mean, one of the things I do is run a support group, and getting new members or volunteers, as you call them, during the pandemic has been almost impossible.
Yes.
And the pandemic has, hardly need me to say this to you, but has done such serious damage to us. You sometimes wonder is actually how you're actually going to move this forward. It's extremely difficult, isn't it?
Absolutely. No, again, that's stating the obvious. I don't think I need to add anything to that. Linda, you want to come in?
Thank you. Yes, I think I can see where this fits. But my point was more to do with the voluntary sector too. And one of the strengths of the voluntary sector is that we have direct contact with patients in a more informal setting, and we know more likely what they think about a lot of the aspects of the healthcare they're getting and what it's all about. So whether we have resources or not, at least we have relationships with patients in a setting where they're likely to say what they really think.
Yeah, I think that's a very important point, and I think it's one of the things that's recognised in terms of statutory organisations and in terms of the ICS, because I think there's an understanding that actually the voluntary sector actually can reach places that other organisations can't. But as I think that one of the challenges for us is going to be how do we get to all the different organisations in a huge area? How do we genuinely give them an opportunity to engage? We can't represent them all. It's not about representing. It's about sort of trying to find a way of enabling them to engage and enabling those voices to be heard, and for those voices to make a difference, not just to be listened to and nodded at, but to make a difference in terms of the range of services and the quality of services that are provided through this new structure.
Yes.
Anyone else have a comment or a thought before we move on? Okay, thanks very much then. Move on to the next item then, please. So, another presentation. Rachel?
Thank you very much. Hi everybody. Thank you so much for inviting me to be a part of your meeting today. I am Rachel Lovesey, and I am the Patient and Public Engagement Manager for the National Cancer Programme, which obviously is based within NHS England. I have been in post now for 6 months, which I think means I'm unofficially I'm not allowed to say that I'm new anymore, although to be honest, I do still feel quite new. But yeah, there's been some amazing work that's been done by my predecessors, and I'm here to talk to you today about the Patient and Public Voices Forum, which we, myself and Lisa, are obviously hoping that somebody might like to volunteer to become involved in, because Patrick is sadly leaving us. So just to say a very formal thank you to Patrick for everything that he has contributed over his time with us. But yes, so we have a Patrick-shaped hole within our forum that we're hoping that one of you might like to fulfil from Thames Valley. So what is the Patient and Public Voices Forum? So as I stated, the Cancer Programme has worked really hard to set up a system to enable patients to be engaged and involved in everything that we do at that national level. So they set up the forum, which was established back in 2019. Obviously not by myself, but by my predecessors. And then obviously COVID hit. So a majority of the time that this has been running has actually been during COVID. So we have is a formal part of the cancer programme. So we have a terms of reference, and we also have a patient representative chair who is Kindwin Giles. And as a forum ourselves, we meet twice a year, but there's obviously lots more that we do in between that as well. So I'm just going to kind of take you through what it is that we do and what it is that you might like to get involved in. So in terms of those twice yearly meetings, they are our biggest way that we come together as a group, really, as a forum. And our next, all of that has been done virtually, but our next meeting is actually going to be face to face in London in October, which we are all obviously really excited about, because I don't think I've met anybody face to face yet. So I'm really looking forward to that and having that opportunity. And I know that others are as well. So those forum meetings that are held on average around every 6 months are always attended by at least 2 national directors. So for this one in October, we have Professor Peter Johnson, who is the clinical director. He will be attending, and also Ed Rose, who is the director for delivery. So the reason that I'm kind of telling you that is just to emphasise the importance that this is given. You know, you have real buy-in from the very senior directors within the cancer programme, and how much they believe in patient engagement and want it to be a success. So they will come along and they'll give presentations on the kind of current picture, but also will take questions and as well, which we find is probably the most fruitful bit, because we get to ask whatever we like, and it's always obviously really interesting. And obviously they have lots to take away from that as well. We also have an optional monthly drop-in session where people can just, the forum members can just drop in and have a bit of a conversation with each other. There's no agenda, but it's a chance to meet with each other, potentially talk over any issues or projects that are currently going on, and just have that time, because again, we don't see each other face to face and we're all based all over the place. So it's nice to have that opportunity to kind of be together. We're also currently piloting a coffee roulette where PPV members meet with cancer programme members in a very informal way. It's not about talking shop. It's more hi, I'm Rachel, I've got 2 cats and 2 kids, although I probably shouldn't say them in that order, to just kind of get to know each other a bit better. Again, because we want PPV members to feel part of that wider programme. So the nitty gritty, though, obviously, is actually getting involved within the programme and the different aspects of that. And those opportunities are sent through by the weekly engagement opportunity bulletin, which I pulled together. And obviously, I'll go into a bit more detail around what kind of opportunities there are in a little while. And we also have a monthly newsletter as well, again, just as an opportunity to share that information. And we have PPV members that will write within that as well. Yeah, so hopefully that's nice and interesting for people. Can I have my next slide, please? So in terms of what we want to achieve, what our objectives are, this has been taken from our terms of reference, and I'm sure that it will be of no surprise to anybody within this group around what it is that we're looking to achieve. But I wanted to kind of take you through this so you can, again, get a bit of a feel for what it is that we're doing. So it's all about bringing actionable on-the-ground intelligence from communities and people affected by cancer into the cancer programme and to relevant decision makers. Obviously, that's really important. To deliver advice, guidance and support to add value to the success of nationally led programme projects and policy, and to generate mutual learning between project teams, communities and people affected by cancer. So again, probably no surprises there. It's all about getting people involved in everything that we do and about power sharing. If I can have my next slide. So who are our PPV members? What does it look like at the moment? So we currently have 30, well, I say 34, but I did actually recruit somebody yesterday. So technically 35 now active PPV members. And as you can see from the diagram, which might need a little bit of updating, but it tends to be pretty accurate, based all over the country. And that's because we try and ensure that our PPV members are aligned to their local alliance. And you guys will obviously understand that completely, because it gives us more of an insight into what is happening locally on the ground. You know, the different communities that people are involved in through their alliance. They're able to then bring that experience and information into the national programme as well. Have my next slide, please. So what do we do? So obviously we represent patient and public voice within the whole programme. We join project teams, meetings, workshops, and so many other different activities. It's always very varied as equal partners and decision makers. Obviously, because we're part of NHS England, we are also part of the patient participation policy that we adhere to. So there are actually 4 levels of engagement. And once you start getting up to level 4 engagement, which is, you know, sitting within those very strategic decision-making forums, then there is an involvement fee that actually comes with that of £75 per half day and £150 for the whole day. At the moment, PPV members that are part of the forum are involved in over 39 different projects within the cancer programme. And they can vary from things such as being involved in the COVID recovery task and finish group, which has been looking at creating the psychosocial toolkits that you might have heard about. You know, we've had patients that have been co-producing those. Yeah, lots and lots of different things and different ways that people can get involved. The members also present at national conferences and will attend other programmes of work where they're called upon from actually outside of the cancer programme. So we have PPV members that are part of the Citizens Advisory Group that's run centrally within NHS England. And obviously we're really proud of that, because it means that, again, the voice of cancer patients is being heard within that programme of work as well. We're also currently looking at how we can better support primary care, because that's something that obviously is coming up all the time in terms of accessibility and concerns around the impact that potentially is having on diagnosis. And there's some work that we are looking at doing outside of the cancer programme that is more supporting primary care itself. So can I have my next slide, please? Obviously, that was really quick from me. So if you have any questions, please ask. But in terms of, if you're interested, then we can have a much longer conversation on a one-to-one if you want to get in touch. But yes, the general process is a bit like applying for a job, to be honest. You have to fill in a short application form. There's a nice informal interview with myself and perhaps the chair, Kynwyn, a short induction, bit of mandatory training, again, nothing that will be of any surprise, things like information governance training. And then, yes, if you are going to be working at and supporting at level 4, then you do have to go onto our electronic staff record for payment purposes. We had to pop everybody onto it last year for tax purposes. So that's it in a nutshell from me, but please do reach out. I know Lisa wants to talk to you a bit more now as well about what that role might look like from within your alliance. But yeah, I'd love to hear from you.
Okay, thanks, Rachel. Does anyone have any questions for Rachel at this point? Or any comments you want to make? Again, let me strongly encourage anyone who's interested to make an application and get in touch with Rachel for an informal discussion. Thanks a lot, Rachel. Move on to the next slide then, please. Okay. Lisa, Linda and Catherine. Yeah.
Can you hear me okay?
Yeah.
Great. So Patrick's got his hand up. So Patrick, I'm not quite sure whether or not that was just to follow on from.
Patrick, do you want to sort of finish off from the last item, please? Yeah.
Yeah, just very briefly. I don't want to hold you up any longer, no. But I mean, just really to reiterate everything Rachel said, and thanks for your kind words, Rachel. I've been on the forum since it started. It's I reluctantly am stepping down, but just can't commit to it in the same way. It's one of the most enjoyable and rewarding pieces of volunteering I have ever done, and I can't recommend it highly enough. You have a real sense of making a difference, engaging with national policymakers. There is a real culture within the NHS cancer programme of co-production, and you are actually involved in putting together policies, developments, supporting national pilots, really being at the cutting edge. And finally, you meet such wonderful people. I've had the real pleasure and privilege to meet people from within the cancer programme, but even more so from the other patients representatives from across the country, where I've learned so much from them that I've hoped to be able to spread wider. But yeah, if you want a volunteering role that's at the cutting edge of cancer development, that really does make a difference and is hugely rewarding, can't recommend it highly enough.
Okay, thanks for that huge endorsement, Patrick. And I hope everyone kind of can think, yes, that's great, I'm going to do that. Okay, Lisa, over to you then.
Thanks, William. Thanks, Patrick. So Patrick has been our delivery group representative as well as being the South East PPV. So we've been very lucky, and that's due to him actually living within Oxfordshire as well. But as Rachel was saying, if we can, it would be really great if we could have the dual role linked with the South East PPV role, with somebody who's obviously working or living, should I say, and supporting kind of the area that our alliance covers. So for those of you that aren't aware, our delivery group, well, the purpose of our delivery group basically is to provide assurance and oversight to the Thames Valley Cancer Alliance Executive Board. It oversees and leads the development and delivery of the work that we have within each of our programs, and it brings together clinicians, other professionals and organisations to make sure that the patient's voice is heard in all of the decisions that we make. The role as well is to endorse relevant national clinical guidelines and policies and procedures, obviously led by NHS England. Now, the meetings that we have, they're sort of in rhythm with that of the executive board. So they're held quarterly, and they're also in the rhythm with regards to the PPG meetings. So there would be an expectation that whoever held that role, like Patrick has held to date, would give an update to this group that we're on today as part of what sort of activities are going on sort of on the ground, and feed that back to our patient forum, and obviously to then take back any discussions that we have within this group back to the delivery group, and obviously then linking in with William to take up to the executive board. So to date we have had obviously Patrick in the role, but not necessarily a specific role description that kind of sets out those expectations. And talking this through with sort of Patrick, he has suggested that obviously would be really useful, just like all of our other roles. So that is something that we have drafted, and looking to perhaps have endorsement from the delivery group next week. That's when their next meeting is, and to look sort of as to what the next steps are taking that forward. Now, as there is kind of a dual role, it would be great if we could kind of combine all of the sort of inductions and interview process in one as part of the South East PPV role. But we do appreciate that there are other sort of areas within the South East that Rachel's reaching out to with regards to kind of representing that PPV role. But if we can have, you know, through Patrick's enthusiasm, a double whammy and have somebody included as part of our delivery group as well as the PPV role, I think that would be really great for our alliance going forward.
Thanks, Lisa. Anyone got any questions to Lisa? Okay, let's move on then to item 6. Right, Lisa, you're still here with Catherine and Linda, so over to whoever's going to kick off in this one.
Is it down to me first? I'm Linda Wilson from Milton Keynes, a long-standing member of Bosom Pals MK, and also a long-standing member of the Thames Valley Breast Cancer Special Group, together with Jan Backhouse, who can't be here today. And this year we raised at the group our thoughts on the literature and information available to breast cancer patients. There's a great deal of stuff, is that the right word, information out there for people, but we weren't sure whether it was always getting through to the people who might benefit from it. You know, you hear from people who say that they're given a huge pile of booklets, etc., on diagnosis, they take them home and they never look at them again. And we wondered if there was some way of addressing this issue, because we felt that there would be items, literature, booklets that would be useful, but it was just a matter of people knowing how to use the stuff, and being able to understand what it was trying to tell them. So Catherine Bailey from the Royal Berkshire Breast Cancer Unit said she would help us, and she asked her fellow nurses in the breast cancer units around the region, the network, what they were giving to their patients. And Jan and I looked at the information available online, and there is a great deal. I think the breast care units agreed that the Breast Cancer Now general leaflet on breast cancer was the one that they recommended, and they had lots of local information. And Jan and I felt that a lot of the general booklets start off telling patients about the aspects of cancer, and the details they'll need to know about treatment and the rest. We felt that you need something more suited to the moment of diagnosis, really, that gives you an overview of cancer and how it places you in the grand scheme of things, rather than going into technicalities straight away. And we came up with the idea of an introductory leaflet of some sort, and an information map to give people an idea of what else is available for them and how it might help them when they're ready, rather than piling everything on them to start with. And we felt there should be some sort of positive message. I mean, this is a difficult one because perhaps the prospects aren't good for everybody that's diagnosed with cancer, but we felt they should be given some context and some idea of, what's going to be helpful about their journey, rather than going straight into the technical details before they've really adjusted to knowing that they've got cancer and they'll be going through treatment for the next months. So we're working on this. It's not easy, but we hope that we can come up with a map, something to guide people through what is out there. And we're also looking at perhaps how some of the leaflets are presented, language, physical presentation, because sometimes it's pale print on shiny paper and stuff like that, which makes it hard for people to read. So language, acronyms, perhaps ease of access, because I was reading something today which suggests that only 22% of people have access to or can use IT successfully. So I think if we can see our way through this, there's perhaps a way of helping people come to terms with their diagnosis and look at the help that's available for them in a more guided way, so that they don't ignore what they've been given because it's all too complicated, but when they're ready, when the point comes when they're ready to find out about things, they know where to look. I mean, there's lots of good information on the internet from Breast Cancer Now and Macmillan, but a lot of it is quite technical and complicated. I think you need a more nuanced approach to help people at different levels get into what they need to know, if they want to know it.
Linda, sorry. I was just going to say that's great, and obviously we've taken this opportunity to showcase the work that Linda and Jan have done as a co-production as part of their involvement on the breast CAG. And it, you know, obviously Linda's gone through about having a look to see what was out there and then using kind of their expertise, their experience, reaching out to kind of networks to feed in for other suggestions that, you know, could be incorporated into this kind of leaflet going forward. And obviously what was the best practice or what was received well. I've just seen that Catherine's joined, so I'm not quite sure. Linda, well done. I'm not quite sure if Catherine wants to add anything to that.
Sorry, thank you. I'm Catherine. I'm the breast nurse consultant here at the Royal Berks, and I worked with Linda and Jan to look at the information for patients. It was very interesting from my point of view that because I think you think that the information's good, but you forget from a patient point of view, you know, what needs to be known and what people would like. So it was very good, I think, for us to get together and go through it. I think we need reminding now and again as healthcare professionals.
Thanks, Catherine. Catherine, anything more you want to add?
No, not unless anybody's got any particular questions. That would be
thank
fine.
you. Does anyone have any questions or comments?
I think it would be useful going forward if we could kind of showcase other examples like this from our other working groups. So whether or not that's another clinical advisory group, whether or not that's obviously part of the delivery group update that the new representative will share. But I think it's really important to share within this group what activities our patients are involved in, and it's not just us presenting as an alliance you know, strategies and policies. It's about kind of the nitty-gritty changes that are helping obviously to improve services within the local area.
Rob, you've got your hand up?
Yes, very briefly, Chairman. I'm not an expert on breast cancer, but I have to say I've, as a support group, which I've run for some 7 years now, keeping leaflets simple is a real challenge. I remember being told when I had bladder cancer, as it was, and I struggled out of the hospital with a big stack of booklets which they'd given me all the sort of information which your previous speakers have been talking about, and I really didn't read any of it.
There you go.
You're in a bit of a shade of stock. What I did do, I sort of went onto the internet. I'm a great advocate of the hospitals, and I deal with Royal Berks. I'm a huge advocate. Hospitals have the right and correct information on their internet. There's some wild stuff on the internet people can read, and it is misleading. You want accurate advice on the hospital website, accompanied by a leaflet. To give somebody up to a dozen leaflets, which they did me, who's going to read that? You're not in the right mood.
Rob, have you finished your point? Okay. Alex, you want to make a point?
Yeah, I just want to say I agree that this is really a big issue. We've got some quite good leaflets for the Reading prostate cancer support group, and the challenge is getting the right information to the people, to the patients, at the right point in their journey. And the day of diagnosis is not the day that you need to give them a pile of stuff, because as previous people have said, no, they just don't read it, and they've forgotten they've got it when they got to the point where it would be useful. So I think that the challenge is not just getting people the right information, but presenting it to them at the right time in their journey. And diagnosis day is not that day. It would be so simple if it were. That's me.
Okay, thanks, Alex. Ian?
Yes, just a brief comment, thank you, Chairman. I think Linda and Rob hit the nail on the head. The new cancer diagnosis and then the treatment going forward as a journey. And actually, I think Rob was suggesting bombarding a patient, particularly with timescales and prognoses and all that sort of stuff. is actually just to say that you're embarking on a journey, and this you know, you will understand more about your condition as you go forward on the journey. And certainly in my group, which is for supporting people with myeloma, you know, the view we've come to is very much that it's a journey, and that sort of takes the pressure off people trying to understand too much information in too short a period of time.
Okay, thanks, Ian. Catherine, you want to come back? You're on mute.
Yes, yeah. So that's kind of, from me, that's what I took away from this. So when the suggestion was for an information map, it was about looking at the pathway and what patients felt they needed at particular points. That was one of the takeaways that we got from this. And now with I can only say from what we do here at the Royal Berks. So when we do something called a holistic needs assessment, at that point, that would be another assessment of what information people needed at that point. If they're not as structured in a patient's pathway as perhaps they could be, then that might be where we're missing giving good information. And the problem there is that that's all given up front, because there isn't those, touch points where you meet the healthcare professional again, or you kind of ask for more information.
Thanks. Linda, do you have the final word in this?
Thank you. I was just going to add, I think it's also can be satisfying for some patients to actually be in control of what they ask for when they themselves have identified that they want it, instead of it being thrust at them.
Yeah, no, I think that's very important. I've got someone else coming in, Jeff Newton.
Unmute. I just wanted to share with you, and it's really outside of this region, but recently, and Linda was involved in this, was the production of a small leaflet by BLMK, Bedfordshire, Luton and Milton Keynes. And it says on the front, just been diagnosed with cancer. And then very simply in a threefold, it gives first of all, suggestions from our experience. Very simple. When you're first diagnosed, what went through your mind? What did you want to know? And then there's a place for notes, and there are some actual photographs of real patients. And you can go online, download this leaflet, or pick it up locally from your hospital GP. And I think, if you could go and look at this, it would be very useful to have something from Thames Valley based on this sort of approach, because it's very personal and from an actual real patient.
Okay, thank you. I think that just reinforces everything that Linda and others have been saying about how important it is to kind of focus on where we are. And I don't think one can say enough times just the whole kind of thing about that initial shock with sort of new diagnosis and, the danger of kind of too much information being pushed at that point in time. Okay, thanks everyone for that. Lisa, you've sort of a final thing to say in terms of the breast CAG?
Yes, I did. So Linda and Jan obviously have been representing the breast CAG for some time now, but sadly Jan is stepping down. She's sort of relinquishing her sort of representative role. She's also been running a breast support group called Bosom Friends for a good number of years now, I think about 18 years. That she's actually handing over to Maggie. So we now have another opportunity for a patient representative to join the breast CAG if they'd like to. So I've just kind of put a couple of points there with regards to what the breast CAG represents. It's quite similar to obviously all of our other tumour specific groups, and CAG standing for Clinical Advisory Group. So it is looking at the integrated care services within their own specialist area. So obviously this is breast cancer, developing and maintaining clinical protocols and guidelines, reviewing operational delivery of pathway of care and agreeing and assessing the aligned standards across obviously all of the Thames Valley in relation to breast cancer care. So we do have a generic CAG role description that sets out the expectations of the role, and all patient activities going forward will be sort of captured as part of the clinical advisory group's work plan. So most of our CAGs, as I've mentioned previously, there's a requirement to have 2 representatives on each of the CAGs, and mainly for peer support for each other and obviously to cover annual leave, etc. But it's making sure that that patient voice is continuously heard throughout, you know, outside of meetings, and rather than just sort of ad hoc, it's encompassed in all of the sort of activities per sort of CAG work stream that's taking place. So if anybody would like to join the breast CAG or would like to perhaps put a call out to their wider networking to see if there's anybody else out there with sort of within their own support group that would be interested, I'm happy to have an informal conversation with them. By all means, send me an email. My email details are there. And we next have the breast CAG group meeting on the 16th of November. So we've still got a couple of months away, but if you'd like to have an informal conversation, and I can introduce you obviously to the breast CAG lead to set out those expectations even further and to obviously endorse involvement, that would be really welcomed.
Okay, thanks, Lisa.
Thank you.
This seems to be a meeting where we're actively recruiting. You know, we've had a number of things. So again, I would certainly encourage people to consider applying, or as Lisa said, reach out to people in your network. So thanks very much, Lisa. Okay, item 7 then. Lisa, still you?
Still me. Okay, so I think at June's meeting, which I was unfortunately unable to attend, Lyndall sort of gave an overview with regards to the National Cancer Patient Experience Survey, in as much as sort of stating that the results were imminently due. So they were actually published on the 6th of July of this year, and the survey involved around about 134 trusts nationally. 2,106 of those that were within our own patch responded out of the 3,615 patients that it was sent to. Now, with regards to sort of the analysing of the data, this is done at trust level, although the Alliance does get to see all of the trust reports, and they are held publicly on PICA's website, and I've included a link within the slides that you can go on and have a look at those results independently. So the whole survey is broken down into questions and themes within those questions. So there are various sort of different topic areas. You know, help from your GP. Were you given sort of one person sort of contact as per sort of a CNS? All of the answers given were presented in a scale of sort of a percentage scale, and looking at just one question, which was overall care, which was question 59. These were the results of our trust, and that was the only question that was scored from 0 to 10. As you can see, the national there was 8.9, and each of our trusts were within that kind of range. Overall, OUH, which is Oxford University Hospitals, showed a slightly better performance overall than sort of other trusts. So as I've mentioned, it's down to the trust to analyse their report findings and to present this to their board. So this is very high level that I'm presenting here, because obviously we need to make sure that the executive boards of each of the trusts can go into the detail, can review sort of any key areas for improvement, looking at sort of what patient involvement they want as part of working groups to take that forward, and to see, you know, if there's a particular themed area that they can kind of concentrate on within those sort of individual projects. So high level, the majority of responses came from those aged between 65 and 74 across all of the trusts, and the most responses per tumour group came from breast cancer patients. So the 3 trusts listed there, you've got Oxford University Hospitals, Buckinghamshire Healthcare Trust and Royal Berkshire Hospital. So all of them scored within expected ranges for quite a number of their questions. Oxford had 20 that scored above the expected range nationally. Bucks had 2 that scored above, and RBH with 1 and just 2 scoring below. But as I say, with regards to the details of action plans going forward, that'll be for the trusts and obviously their executive board to discuss how they would like to progress that, with support obviously from us as an alliance if we're looking at collaborative working across all of the trusts if certain themes have been identified. So in addition to those broken down 60 odd questions, there were 3 open-ended questions where patients had an opportunity to actually state some narrative. I've listed those 3 questions there, and out of the percentage shown, that was out of 59,000 people who were asked, completed that those questions, so 84%, 62% and 44%. The thematic sort of analysis highlighted 7 main themes as important to the experiences of those cancer patients. I've listed the 7 here. So we've got gratitude. So a very high level of gratitude was given to our trust staff and obviously the clinical staff associated with a patient's care pathway. In particular, kindness and compassion of staff were frequently mentioned as having a positive impact. The second theme was around negative experience within general practice. So expectations from cancer patients regarding the care was often unmet. Some patients reported a poor diagnosis experience, feeling that GPs failed to address concerns and symptoms, resulting perhaps in misdiagnosis. And it was also highlighted that patients felt that GP offered minimal to no communication or follow-up. The third theme was around communication for patients. So patient wished to feel better informed about their cancer treatment and care. There were specific areas mentioned, including information on side effects of treatment, detailed information on cancer type, information on type of treatment and post-surgery advice. Findings emphasise the need for a single point of contact during treatment, so a CNS, and further follow-up support was often sporadic or absent in many of the experiences, and telephone appointments were found to be problematic. The fourth theme there is coordination of cancer care. So communication between different departments and hospitals was found to be problematic for many patients, and it was felt that it was caused, delayed and resulted in undue anxiety. Waiting times, so long waiting times were highlighted as an issue with a variety of examples shared. It was noticeable that some respondents felt that improvement in these areas would have had a positive impact upon treatment, outcome or prognosis. Number 6, negative experience with hospital staff. So as I've mentioned before, most comments concerning members of staff were overwhelmingly favourable and obviously in relation to gratitude. However, there were a few issues highlighting relating to staff availability and patients not receiving sort of sufficient time maybe to ask questions. Whilst not common, some patients also reported poor interactions with staff, and this had a general sort of impact on the impressions and quality of care. So the last theme was wider hospital issues, so problems arising from lack of privacy on wards, perhaps noise levels as well, ongoing in respect of sort of parking issues at some of our trusts, and poor quality of food. So we don't actually receive the kind of qualitative data of trust directly at the moment. This is the thematic data of the national report. As I say, it's all in the public domain. You can review it sort of as your leisure if you'd like to. But what we would like to do going forward is sort of to work with our trust lead clinicians, cancer nurses, to get a better overview of the specifics relating to obviously the Thames Valley trusts, and keen for the members of this group as part of the PPG to be able to have an opportunity to be involved in that analysis and perhaps support the working groups within each of the trusts if it happens to fall within sort of Buckinghamshire, Oxfordshire, Berkshire, if that's the sort of local area that they live in as well, and they have sort of a sort of more personal interest in that particular area also. Any questions? I appreciate that I've obviously rattled through that, but
Any questions or comments? Yes.
Michael.
Yeah, go ahead.
Hello, everybody. First off, I'll say a hello and introduction, as I'm very new to this group and this is my first meeting. So my name's Michael and I am the new lead cancer nurse who's just started in July. I'm still going to use the word new because technically this is the start of my 3rd month, debating at which point you're not allowed to call yourself new anymore, but we're going to run with that for today. I guess a bit of a question for our Alliance staff members, and perhaps something we can take off offline. But just as we're looking at the results and the comparisons in some respects between the likes of Buckinghamshire Trust and Oxford Trust, we of course will do our own analysis at a local level. We do have some plans for that. We've already discussed with board. Bucks are going to go down the angle of really triangulating our cancer patient experience survey results alongside some of our other patient experience data we have already, because this is one snapshot from one period in a year's time. If we look locally, we only had 135 responses, but we have a mass of other patient experience data, which is often telling us a different story. So we're going to be looking at it from a slightly different angle in Bucks, which is really exciting. I can tell you more about that over the coming months. But my question for the Alliance staff would be, when we look at the comparators across the Thames Valley region, there's different scores, but what other data have you got on the other trusts that can kind of tell us a bit of a story? So for example, we saw that Bucks had a score of 8.8, whereas Oxford has a score of 9.0. How does that correlate in terms of their performance in terms of 2-week waits, in terms of the 61-day targets? There's data that you as an Alliance might have that we perhaps locally wouldn't have as in a trust, and I'm just wondering if you had any insights from that perspective.
Lisa, are you able to respond to that, or prefer to deal with it offline?
I'll come in if you like. It's Lyndall here. So you're right, Michael. I think it is also good to look at cancer performance data against the sort of national cancer patient experience stuff, and that's certainly something that we can do and then share. I think this is a conversation we can pick up with you sort of after the meeting. I think the important thing for everyone here is to know that, you know, this patient experience survey has happened, and yes, it is a snapshot in time, but important to hear, you know, your enthusiasm at looking at the data and actually understanding it from a Bucks perspective. And you're right to be triangulating it with other information. And I think it's about having that sort of plan across the system for the sort of Bob area, I mean for the Bucks area, of what you're going to do to try and address some of the issues that are appearing here, or potentially in other areas that you have already looked at. So what we don't want to see is that these things happen and then no one really listens or does anything about it. And that's certainly not what we're going to do here, that we're going to also share this through the clinical advisory groups by tumour site as well, and try and sort of pick up some bits that we can use for quality improvement work going forward. And actually, we've seen some really good examples. Mark's left the call now, but actually, well, it was shared at the last patient partnership group. RBH actually did a really excellent piece of work as part of the Cancer Collaborative last year, and that's actually improved some of the patient literature in different languages that has actually engaged a diverse community and improved the services going forward. So I think they're the things that we want to see, that there's going to be some action from each of the trusts in trying to support the work going forward. Thanks, Michael.
Thanks, Lyndall.
Sorry, that was a long answer to what you asked.
Okay, thanks, Lyndall. Thanks, everyone. Lisa, thanks for this very kind of expansive presentation. I think what you've highlighted, particularly thematically, is, you know, it rings, I think, with a lot of our experiences. And I think the challenge is how do service providers actually respond to these kind of messages, so to try and improve the quality of all their services. Okay, thanks very much then. Moving on then to item 8. Lisa, I think it's you and Rob.
So I don't think Rob's yet joined. I'm just having a look through the...
I'm here.
Oh,
Rob is here.
Brilliant. Okay, so just before I introduce Rob, I just wanted to take this as an opportunity to thank you as a group for the various different sort of involvement activities that you've been kind of involved in to date. So I know following the June meeting, Dr. Susan Curran, she circulated a psychological support survey, and she sort of sent that out to the PPG members. I appreciate that there was a few sort of technical issues with regards to being able to submit it initially, but she is collating that information. So I just want to say a huge thank you, and that's how, you know, that's the purpose of this kind of group, to really get involved in sort of activities going forward, such as obviously that mapping process that sort of Dr. Susan kind of went through with you. Looking at working with our partners at Macmillan and obviously the staff and patients carers support groups, we're looking at holding an engagement event in Buckinghamshire in November. Yesterday we kind of all got together, members of various different support groups within that area, as well as Oxford initially, face to face, just talking about the work within the support groups, what activities they're involved in, how sort of that wider reaching patient voice and engagement can be incorporated to make those service changes. And again, that's through your enthusiasm and your participation. So again, I wanted to say thank you for those that came along to that meeting yesterday, and hopefully will obviously be helping us taking that event forward in November. So if I could introduce Rob, I'm not sure, Rob, if you have your camera available. But I just wanted to introduce Rob Stewart. He's our clinical acute oncologist at the Oxford University Hospital, and he wanted to kind of talk to the PPG today about acute oncology services. I know we've spoken about this previously, and what it is that we can do as a group to maybe support that sort of service, and you know, looking at where improvements can be made, but what it actually means to have that service in the first place, if those of you on the group have obviously never had direct experience yourself.
Thank you, Lisa. So thank you very much for inviting me to come and speak to you today. I know it's said all the time, people get excited, but I am genuinely excited and really pleased to be here, because obviously you spend your life speaking to individual patients, but when you've got a leadership role that involves a whole group of patients, you rarely get the opportunity to actually speak to a group. So it is really good to be here. I'm also here with one of the lead nurses from Frimley Health, who has responsibility at Frimley Health for their acute oncology service. And what we're planning to do between us today is split our 10 minutes. I would love to have more time, but we're going to split our 10 minutes into two sections. And the overall message I want you to take away today relates to awareness of acute oncology. So the first half of the presentation is, I hope I'm going to increase your awareness of what acute oncology is. And then the second part of the presentation is about trying to enable patients and groups such as yourself to increase our awareness as people who deliver an acute oncology service about what the patient experience is of acute oncology. Because without that sort of feedback, like most things, we just carry on doing the same thing, assuming that what we're doing is the right way of going about business. And obviously, if we've got that right, you could argue that's fine. But if we're not doing as well as we should be, then we will carry on performing not as well as we should do. Now, for technical reasons, I need to switch devices and share slides. So I'm just going to this one. So hopefully, yeah, you should be able to see some slides. So, as I said, so my name is Robert Stewart. I'm a consultant clinical oncologist in Oxford. And I think I'm just going to share some data to begin with, that even if you've not seen the exact data, I'm sure you're aware of this. So for all of us, our lifetime risk of having a cancer diagnosis is increasing. And we're getting to the stage now where we think for 50% of us, we will be told at some stage in our lives that we have cancer. And that translates into getting on towards sort of 300 to 400,000 new cancer diagnoses per year in this country. And in turn, that translates to 2 to 3.5 million people living with or beyond a diagnosis of cancer. So these are big numbers. And again, I'm not sure if you're aware of this sort of slide, but for the ideal way of managing patients with a new cancer diagnosis is that they go on this 62-day pathway. So essentially, ideal world, go and see a GP, say, look, I've noticed this lump or I've got this new symptom. GP assesses you and says, oh, I'm concerned you have cancer. So they refer to the cancer specialist or team, and they need to make that referral to the specialist and for the specialist to begin that assessment within 14 days. There's then an investigative phase that doesn't have a specified time associated with it. And then once the cancer diagnosis has been made and a treatment plan has been agreed with the cancer specialist, there's then a 31-day target for that patient to begin treatment. And that whole process should not take any longer than 62 days. And there are some new targets on the way. So that's what should be happening in theory. Now, in practice, so if it happens in theory, all well and good. But in practice, what we see is that for about 25% of patients with a new cancer diagnosis, it doesn't happen via this pathway. It happens because the patient is acutely admitted to hospital with something that might not even be thought of being related to cancer in the first place. We know that once patients start their treatments, they can have complications of those treatments. And we also know across that whole pathway, patients actually get admitted to hospital with complications of the cancer itself. And what that means is that actually that particular pathway, great for planned cancer care, but for unplanned cancer care, that doesn't cover everything. And just over 10 years ago now, that was recognised by this national report, which essentially reviewed the care of patients who died within 30 days of receiving what we've gone to term sort of systemic anti-cancer therapy, or SACT, or what for most people it generally means chemotherapy. The national response to the information in that report by the National Chemotherapy Advisory Group was that all hospitals with emergency departments, so not just those with a cancer service, should establish what they described as an acute oncology service that essentially brought together all those people who might be involved in the unplanned or emergency care of patients with cancer, whether that's at the beginning of their diagnosis or due to complications of their cancer or complications of the treatment they are receiving for the cancer. So rather than the response to these patients being ad hoc and dependent upon what sort of expertise you might happen to have within a hospital, it spelled out very clearly that a robust service needed to be in place with various key members, so that irrespective of where you might live in the country, if you turned up in an A&E department with a complication related to cancer, you could expect the same quality of care. So essentially, acute oncology is the service that responds to the acute needs of patients with a new cancer diagnosis via an emergency admission, the complications of cancer, and the complications of treatment. And when I arrived on the call today, I noticed that you were talking about the breast clinical advisory group, and obviously there are tumour site specific clinical advisory groups, but I would like you all to take away the message that actually there's another service that isn't directly related to a specific cancer diagnosis. It's the acute oncology service that works within and around all of those other services when things aren't quite going to plan. And so that's acute oncology. So I'm not sure, so we're rushed for time. So I don't know if I'm happy to take questions now before Lara comes on and then talks about how she's tried to measure or collect patient experience.
Okay, anyone got any kind of brief questions?
Cool.
Okay. Okay, let's move on then to your colleague then, Rob.
Unmute. Thank you, everyone. I've got a double screen, so I'm never quite sure if I'm sharing my screen or not. Are you able to see my slides?
We can just see you at the moment.
Aha, then I need to move to this screen. Can you see it now?
No.
Oh, hang on a minute. Display.
Technology is great when it works.
Please tell me you can see it now.
Nope.
Not yet.
No, not yet. That's terrible. Hold on a second. Let me just see.
Lara, would it be useful for me to share? Because I've got your email through now, so if it helps.
It might be. I think I just shared it from my wrong session, so sorry about that. But whilst I'm trying to get there, I will just explain who I am. I'm Laura Ross Kelly. I work for Frimley Health.
Yes, it's not showing now, Laura. Yeah.
Is it showing?
Yeah.
Oh, I think it's my network. I think it's very slow today. We've lost network a couple of times. Sorry about that, guys. Thank you very much for inviting me as well. So I obviously work in acute oncology. Are we all right? You can see my slide?
Yep.
In Frimley Health, so across 2 DGH hospitals, Frimley Park Hospital and Wexham Park Hospital. And I started in June 2018, and I was told I was going to be peer reviewed in December, and I needed to get a patient experience survey up and running in preparation for our quality surveillance peer review. So I did what all nurses do and not try and reinvent the wheel, but try and find out what experience surveys there were about already for acute oncology. And at that point, Royal Surrey County Hospital, which is Frimley Park's Alliance, St Luke's Cancer Alliance, had a patient experience survey. And we took that survey to our patient experience group locally in the trust and started giving it to patients who were seen by the acute oncology services after an emergency admission. So what we essentially do is at the end of the month, we go through a list of all the patients that we had referrals for with our administrators, and then send out a paper survey to all of the patients who we think are appropriate to send the survey to. We try not to send to patients who perhaps have been discharged from hospital and going to hospice for care there, or end of life care at home, because we feel that we like to know about our service, but obviously we don't want to disrupt the time that people have together when they're nearing end of life. So the experience survey sent out a paper copy, but we've also included a QR code for patients or their relatives to complete online for us. Now, back in 2018 and 2019, we had a reasonable response rate between 15 and 20%. But unfortunately, in the last few years, our response rate has dropped significantly. So about 5% now, which isn't great. And we need to really look at that. Now, the next few slides, I appreciate a very small font, but it kind of shows what's in our survey. So a little bit about which hospital you were in, Frimley Park or Wexham Park, who's completing the questionnaire. Is it the patient, their relatives, their carer, or are people doing it jointly? And then what type of cancer treatment they are undergoing, where they're having their treatment, because of course we work in a DGH, which is a cancer unit, not a cancer centre, and our patients may be treated anywhere and everywhere. We've had patients from London, from Devon, because perhaps they're just driving past and not feeling well and attend A&E, so they could be treated anywhere. And then a couple of questions that we want to find out: how did they get in to hospital? Did they try and phone their cancer centre, their chemotherapy hotline, their clinical nurse specialist, to trying to find out How easy was it for them to get help? Could we potentially have looked at avoiding an emergency admission? You know, so those are the type of information bits and pieces that we wanted to get. And then how helpful was that person on the phone? Were they given a clear information? Did they feel confident in their advice? And also, based on our National Cancer Patient Experience Survey from last year, we put a question in about, did you contact your GP or primary care team prior to attending hospital? In particular, this was because I think a lot of our patients were really worried about coming into hospital during the COVID pandemic and potentially being in an A&E area with mixed patients and high risk of infection with already immunocompromised systems. So we thought that may be helpful. The next part of the question is, where in the hospital did they come to? Was it through a nurse-led clinic? Was it through outpatients, chemo day unit, or straight into emergency department? And then we wanted to know typically if it was a day or a night admission, and then most importantly, what type of symptoms patients were coming in with. And then a couple of demographic things. How quickly were they seen by someone from acute oncology? Did they feel that they were listened to? Did the acute oncology team understand what was going on with them? Were relatives given an opportunity to ask any questions? Did they have confidence in the A&E doctors or nurses? And general care in the wards, in the hospital, the medical or nursing teams? And then again about privacy and dignity. And then we also wanted to know if their cancer nurse specialist was involved in their care, because often what happens is acute oncology will manage the patient's emergency scenario, and then we'll hand them back over to their site-specific teams who know them very well. But then again, you've got the caveat of patients not being treated in this hospital, so their site-specific cancer nurses probably won't be seeing them and may not even know that they've been admitted into another hospital unless we get in touch with everyone. And then a bit about how was their overall rating of their care during the admission, and then a free text box for them to put any comments in there. And a bit of demographics there as well, what type of cancer and age and things like that. So the challenges are at the moment really trying to get engagement. Our response rate is very poor, and I think a lot of the reasons are patients are getting a lot of information. They're getting friends and family requests, they're getting local site-specific surveys. They've just answered the National Cancer Patient Experience Survey, and then our Acute Oncology Survey. I do think there's still a confusion about what is acute oncology and which is oncology. We often may see a patient only once and then hand them back to their site-specific team. So that makes it difficult. And I do think the majority of the negative responses in some of our surveys were about environment, ward stay, contact with GPs, communication between GPs and cancer centres. So really looking at how we can feed that back. I suppose from a Frimley Health point of view, we'd like to work with the Alliance to standardise acute oncology services across the alliances and make it meaningful. And that's why I think it's important for Rob and I to find out what you can do to help us to get engagement, making sure that every feedback form that I see, I do feedback to patients. It's anonymous, but I give them the option to leave their telephone number and name there if they'd like me to give them a call back. I've only had about 3 patients in the last year who've asked for a call back, and the majority of the time that's all been related to stay in the hospital environment, not having a side room, not being able to see their oncologist, and then perhaps not understanding that the oncologist will not visit them on site. And then I think we need to reevaluate perhaps the questions. Some of them do feel as if we're duplicating the National Cancer Patient Experience Survey questions. And then I think my biggest job is to feed back to the cancer site specific teams, in particular if the CNSs haven't seen the patients. And we did see about 55% of patients hadn't been seen by their site specific CNSs. So we need to get better working within our inpatient cancer teams as well. And then perhaps there's something about the accessibility to complete the surveys, paper copies. Is that the best way? Online, is that the best way? I'm not sure we're always managing to get a good response. Perhaps maybe we're not doing it right. So I hope that was helpful, just to give you an understanding of what we do and how we're trying to collate the data in my normal day-to-day job. And I'm very happy to take any questions.
Thanks, Laura. We're getting a bit tight on time. So, Rob, you have your hand up. You want to ask a question, maybe, Mark?
Hear me?
Yeah. Go ahead.
Yeah. Just quickie. The General Stewart made a point about the growth in cancer, and he said 400,000 annually within shortest time. That's a pretty staggering growth, Stuart. And I just wonder, is this going? Why is this? Do we know?
Sorry, Rob, I think you were breaking up a bit there. Could you just sort of just concisely repeat your question, please?
Well, I'll try one. Can you hear?
I can hear you now, yeah.
Well, my question was, especially who data there that cancer was growing essentially and would reach 400,000 all time. I just wonder why it was.
Rob, were you able to hear that?
Right, I've not heard it, so I'm making an assumption about the question. So I think it relates to the statistics at the beginning, about the increasing incidence of a cancer diagnosis. Why is that happening?
Yeah,
correct.
So essentially, I suppose the risk of cancer increases with increasing age.
Oh, right.
We've got the sort of elderly population is growing because of improvements in all sorts of other aspects of life. And we're getting better at preventing and treating and managing other disease types. So essentially something else will happen to us all. And therefore, because we're not great at preventing cancer, then that's what we're seeing at the moment. As an oncologist, my response to that question sometimes is that I'm really shocked and surprised why we don't all get cancer when we're about 1 year old, and our bodies are actually quite amazing in preventing us from getting cancer at all. So those figures, they don't surprise me in terms of the improvements in overall, I'm not just going to say healthcare, but just in terms of overall sort of life. But something then happens as we get older.
Thank you very much.
Okay, thanks, Rob. Does anyone have any other quick questions or points they want to make? No? Okay, well, thanks very much, Laura and Rob. Very interesting. Thanks for joining us.
Thank you. I think I will need to speak to somebody at some stage about how we move from discussing this matter into some action, but I appreciate time is tight at the moment. I've also got other commitments, so I will liaise with Lisa and Lyndall and Lara, and we'll go from there.
Indeed. Come back and we'll look.
Thank you very much.
Forward. Thanks, Rob. Okay, thanks then. Okay, item 9. Then I'll make this very brief. This, in fact, I think is the first anniversary of the meetings. Although it's not the first, I think I didn't come in until March. So happy first anniversary, if I can say. I think what I'm keen to do is to kind of constantly look at kind of updating what we're doing in this meeting and making sure that we're doing things in the right sort of format, in the right way. So clearly, as well as sharing updates in terms of what we're doing, I think what it would be really helpful is try to understand what does the group want in terms of future ideas. Do you want more speakers? Do we want topics about what's happening with other patient groups? do people have particular thoughts about what they might want? Lisa, do you have anything you want to add to that before we open it up?
So I know that I spoke with a couple of our stakeholders yesterday and patient support groups who said that they wouldn't mind coming along and kind of sharing what activities that they're sort of involved in, but looking at feedback within the PPG. So not just necessarily talking about a fundraising event that they're hosting, but you know, what activities they're involved in as part of maybe a clinical advisory group that they're attached to, you know, obviously our delivery group as well. So I know that Emma, she obviously mentioned on the call earlier on, she's linked in with the patient participation groups of the local surgeries within Oxfordshire, and she has offered to come along to a meeting whenever we would like to kind of give an overview about what her work entails and if there's sort of wider patient engagement that we can have as part of that also.
Okay. Lisa, we're seeing a copy, I think, of your Teams screen rather than anything else. So
I think that's Rob's. I don't think it's mine.
All right, it's Rob. Okay. The technology. Okay. Can you get the slides up again? The last set, so we can.
Let's see.
Okay, I think it's got now. That's good. Thank you. That's great. So sorry, I didn't mean to interrupt. Just getting distracted by the screen. Anything else you want to add to that, Lisa?
No, we're looking at obviously getting the schedule formalised for the executive board for next year, along with the delivery group, and we have to make sure that the rhythm for these particular PPG meetings tie in with that also. So we'll probably share that in December at the next meeting.
Okay, thanks everyone. So if people have any thoughts, views, please drop Lisa an email, because I think it's really important that the agendas continue to be relevant. So please let Lisa have your ideas. Okay, and then finally, item 11, any other business? Does anyone have anything they want to raise under AOB? No? Okay, well, thank you very much for your participation. We've run over slightly, but I hope you felt it was worth it. As I said earlier, the slides will be distributed. I think it's probably important that they distribute sort of quite quickly this time, because there's quite a lot of asks contained within them and contact details. So we'll try and get those out separately from the minutes, which will take a bit longer to get out. So thanks everyone for your participation. Enjoy the rest of your day and take care. Bye.
Thanks everyone. Thanks, William.
Bye.
Hello, Lisa. Well done.
Hi.
Is Patrick still there?